And I did want to tell you, because I'm going to be presenting some additional research that BMA has done, and we're just posting today, and I want to talk about that. But you heard me yesterday mention several of our research reports, and I did want to tell you that during the course of the last year, BMA created a research arm. And we've been doing research and public reports since we've begun BMA, but we are sort of trying to create a more robust platform for that. And we call it the Center for Innovation in Medicare Advantage. So be on the lookout for, if you see BMA Center for Innovation in Medicare Advantage, that's our research arm. So we are closely linked, but that is where that's our platform for research. And we hope that gets some good attention. So we put out a number of reports recently, and I'll be talking about two of them this morning, and that is specifically, they're specifically around enrollment demographics, trends over the last 5 years, and a report we came out with recently about the enrollment process itself and some ways to modernize that enrollment process. So let's begin. Slide, next slide. Yeah. So, of course, today begins the open enrollment season. That's a big deal. It's October 15th through December 7th every year. It is when everyone in Medicare has the opportunity to modify their changes, to make changes. They don't have to. They can stay with what they have. About a little bit later about some of the changes that people make, but it is a chance for beneficiaries to make a decision between Medicare and Medicare Advantage, or to change their Medicare Advantage plan. So this presentation is going to talk about some of this new research that the actuarial firm Milliman did for us to really reflect back over 5 years, to look at again, who's in Medicare Advantage, and also about how they switch back and forth between Medicare Advantage and fee-for-service if they do. So, and then we're going to close with some recommendations from a report we did with HMA, Health Management Associates, worked with us in doing interviews and really identifying some of the problems and difficulties and challenges that beneficiaries have in the current enrollment process. While there have been changes made in recent years, there's work to be done to modernize the enrollment process, and we have some pretty bold ideas. So we'll begin. So the demographics, we've been following enrollment every year. We post an enrollment map on our website. If you haven't looked at it, it is by county, by state, and by congressional district. So you can find out how many beneficiaries are in each congressional district, or where they are in the country, the top states, the top districts. There are over 60 districts with more than 50% MA penetration. But broadly speaking, there are about 25 million beneficiaries in Medicare Advantage now, and CMS has projected there will be about 27 million in 2021 as a result of this open enrollment. And of course, every day, 10,000 more seniors become eligible, and many of them, of course, are signing up for Medicare, not most. So we wanted to better understand the population. We've been doing this again. There's lots of information, but we wanted to look at it. So did a report earlier this year using the Medicare Current Beneficiary Survey, MCBS data. It's given us a lot of insight into beneficiaries. One highlight, you can see that report on our website, of course. ATI Advisory did that report for us, which was great. And it did identify the fact that Medicare Advantage beneficiaries have higher social risk factors than those in traditional fee-for-service, including higher rates of food insecurity, lower levels of education, and less English proficiency. And that really follows through in other reports we've done, and in this one that we're releasing today. But building on that research, we have a new report today that, as I say, was conducted by Milliman. The previous report was 2017 data. This is 2019 claims data, so different data sources, hard to say, that compare the demographics of enrollees in Medicare Advantage, traditional Medicare, and, as I said, examine the movement of beneficiaries. So let's get right into some of the data. So Milliman reported a 60% increase in Medicare Advantage enrollment from 2013 to 2019. You've seen that because you've seen the enrollment numbers go up basically 8% a year, pretty steadily. While in traditional Medicare, the enrollment numbers went up 5% during the same time frame. So that's a dramatic difference. You're seeing the movement to Medicare Advantage. Interestingly, minority beneficiaries were very much a part of this enrollment surge. 31.5% of Medicare Advantage enrollment are now beneficiaries from minority communities, as compared to just over 20% in traditional Medicare. And dual eligibles also increasingly choosing Medicare Advantage to meet their healthcare needs. The enrollment, this enrollment cohort in Medicare Advantage jumped from 125% by 125% from 2013 to 19, even as it dropped in traditional Medicare. So again, seeing more movement by dual eligibles to Medicare Advantage. And of course, many of them already been in managed care in Medicaid, so they may be more accustomed to, this is my commentary, more accustomed to a managed care option, and found it beneficial because they made that choice. Geographically, 83% of Medicare live in urban areas, that's urban and suburban areas, compared to 74% for traditional Medicare. This is a slight increase from 2013. So next slide. So a little more information about, so here is now some very interesting findings about the movement. Did not seen this research before, the movement of what really happened. How did enrollees switch? They switch back and forth, they can, as we know, during this period of time. And those who are dual eligibles can switch every month. So there could be some more back and forth there. But of the 53 million beneficiaries in this cohort, and again, this is not new people coming in each year. They took the group of people who were in as of 2013 and followed them for 5 years to see what they did. So it's not everyone in Medicare. It is just that, well, not a small group, 53 million beneficiaries. And they switched between MA and fee-for-service over 8 million times during that 5-year period, including people who might have switched multiple times. 41 million maintained their original coverage for the entire period. So in some ways, the majority do maintain what their original choice is, but quite a few do switch. Medicare Advantage enrollees were more likely to remain in Medicare Advantage. So 85% of those who started with Medicare Advantage in 2013 stayed with Medicare Advantage. Again, they might have switched plans, but they stayed within Medicare Advantage, compared to 81% in fee-for-service. Not a huge difference, but 4% is still notable. Medicare Advantage also showed a retention rate of 85% among racial and ethnic minority populations, whereas in traditional Medicare, their retention rate with minorities was 71%. So again, consistent with what we said before, they are choosing Medicare Advantage even after they have chosen a traditional Medicare or defaulted into traditional Medicare. We'll talk more about that later. In addition, 15% of this cohort of the 2013 fee-for-service beneficiaries moved into Medicare Advantage during this period of time, compared to 6% who left Medicare Advantage to go to fee-for-service. So it's more stickiness in Medicare Advantage. So why this matters? It certainly makes several points that are pretty interesting, and it certainly shows that Medicare Advantage population is growing. It's growing pretty rapidly. This study did not project the future, although we see CMS projecting the future, as do basically almost every other Medicare Advantage pundit, if I can call them that, projects continued robust enrollment growth in Medicare Advantage. 62%, with 62% of minority beneficiaries choosing Medicare Advantage, certainly the path to addressing racial disparities and health equity really runs through Medicare Advantage. We're not responsible alone. Traditional Medicare has work to do for sure. Our health system has work to do. You'll hear more about that later in a fantastic panel we have coming up. But the fact is that Medicare Advantage, and you'll see many of the plans, know this, and they are certainly being very attentive to the changes they can make to address health equity. And the dynamic growth in enrollment amongst dual eligibles also places a responsibility on Medicare Advantage to provide some of our most vulnerable seniors. These are our poorest seniors who are choosing Medicare Advantage to really be able to provide better care for them. And it may have to do, of course, some of the supplemental benefits, although but in the integrated system, and really moving away from a fee-for-service system that is fragmented and problematic for many to a more coordinated care, integrated care that benefits everyone, but certainly the dual eligible population, many of them, not all, but many of them with chronic conditions, I may find that really valuable. So I think we have another slide. Yeah. So now we're going into the second report that came out just a few weeks ago, which again, as I say, we worked on with HMA. And again, it's the backdrop of those numbers that you saw. We had already been thinking and have worked really for almost the last year to really engage a number of stakeholders, people who work on enrollment all the time, who counsel beneficiaries, who are, of course, plans and providers, as well as some of the beneficiary groups themselves, to tell us about what they saw as problems in enrollment process and how we might be able to make that easier and simpler and actually more individualized. So we do have some suggestions. Well, what we know from previous research, by the way, ourselves, is we have polled seniors and we have seen a reduction in these numbers. When we started, it was about 66% of seniors were unaware of the option of Medicare Advantage at their first open enrollment. That's down to 45%. So some of the changes have been made, dealing in the handbook and Plan Finder, and just better understanding about the option between traditional Medicare and Medicare Advantage has helped. We have pushed some of that, pushed CMS to better explain that initial choice people have. Do you want a fee-for-service system? Does that work best for you? Would an integrated care system be appealing? What does that mean? We're sort of not the new kid on the block anymore, Medicare Advantage. So increasingly seniors know about it, but it still is astounding that almost 50% of seniors say they do not know about Medicare Advantage, which is also probably one of the reasons that we see seniors switching when they realize that there's another option after 1 year enrollment or 2 years of enrollment, switching to Medicare Advantage as being simpler, better value, extra benefits, and an integrated system of care. You probably may know this, but certainly seniors who do not make a choice, we believe that we want to encourage people to make a choice, but seniors who don't make a choice default into traditional fee-for-service Medicare, which may or may not be best to move to suit their individual needs. So some of our goals are really to make sure that there are fewer people defaulting and more people making an active choice. Because the delayed or wrong choices can lead to costly penalties. Many of you know about that, those Part B penalties. They're pretty severe and they last a long time. And then, of course, it can be coverage gaps. Some people choose to cover those coverage gaps with Medigap if they're in traditional Medicare, but some can't afford a Medigap policy, and they just may not be making the best choice for themselves, either medically or financially. And with 10,000 seniors, I mentioned this, aging into Medicare each day, there's an urgent need for us to modernize the Medicare enrollment process. So we've identified some areas of concern, and this is sort of it condenses it. So I do encourage you to look to the report, Empowering Beneficiaries and Modernizing Medicare Enrollment. On that report, it explains a lot of this. It's really very thorough and informative. I've had people tell me who've read it that they were surprised, and they know Medicare well, surprised how complicated it can be. So here are the challenges. There's no single government entity responsible for the entire enrollment process. It starts with Social Security Administration telling you that you're eligible for Medicare, telling you how much you have to pay for Part B, and then need to figure out how to go to CMS and get all the information there, or go to some other private sources. And our own polling shows that CMS is really the trusted source here, but it's confusing between Social Security and Medicare Advantage, both in the enrollment process and honestly, even when you have questions about your bills or about coverage or any of that, who do you talk to? So that's the first big challenge. Second is this penalty, which I just mentioned, about a delay or even the wrong choice, where you can be penalized financially or actually find yourself not in the right choice for yourself. Constrained timeline and resources for education and outreach. There's been a lot of discussion about this over the years. You have an opportunity to enroll. You get information 3 months before the month of your 65th birthday, and you have to 3 months afterwards. Sounds like a long time, but in fact, a lot of us who have turned 65 already, I'm one of them, you're kind of shocked to turn 65. It takes you a little bit to focus on that, to focus on the decisions you have to make and the opportunities. And one of them, of course, is enrollment in Medicare. And so it takes a while for people to figure this all out. And we're suggesting that, that we deal with that. I'll get to some of the answers in a minute. So this timeline is, education is a big issue. I will also mention here too, is that even those who are 65 and unemployed don't know what to do. Do they keep their employee coverage or don't? What do they do? We have an answer for that as well. The inability to meaningfully compare coverage options. And again, seen the plan finder and the handbook, really try and work on this, but we still think there's ways to go to help individualize the comparison tools, make sure people understand how it meets their clinical or financial needs, and understand that those needs could change over time, which is why they do have a chance to change their enrollment options annually. But you should to consider that and find ways to make that more meaningful. And again, there are a lot of choices in MA also if you choose MA. So how do you filter those choices in a way that could help people not get discouraged by the process? And the information process, again, I'm just folding into that, are not necessarily tailored to those individual needs. So here are some of our solutions. Next slide. Okay, and again, there's some more details in the report. I'll try and flesh this out a little bit as we're speaking here, but we are suggesting, this is would take a statutory change, is that HHS be the solely responsible for Medicare enrollment, that you get that information from CMS. There's ACL, and you'll hear from the administrator later, who supervises the volunteer government-funded counselors, so they get information from there. But we do think it would be much simpler for beneficiaries to know that it is HHS, not Social Security, that actually runs this process. And given the fact that not everyone takes Social Security now at 65, in fact, many don't, encouraged to delay it, and increasingly so, many people are working, and people have other sources of coverage. So I understood in the beginning while this was done, so this is really a way of modernizing it. It just isn't exactly in sync with Social Security. However, we do still think Social Security should be able to, and it's being done in other situations, be able to deduct your monthly premium for Part B out of your Social Security check once you're taking it. So secondly, we want to standardize and modernize the educational materials for current and prospective beneficiaries. Again, we think that beneficiaries should get information when they turn 64, so they can begin to think about this, talk to their loved ones, consult with counselors, whether brokers or agents or SHIP counselors, and be able to begin to think about what they need. We do think that CMS should be responsible for sending employers information about what they should do for their employees and pass that along to employees, because that's confusing. And that's an increasing number of people who are still working at 65. And that they also should be monitoring information and sort of giving a good housekeeping seal of approval with using their sort of stamp of, yes, CMS has looked at this. Because there's a lot of material on the web that's excellent. There's also material that's not. And being able to have someone review that and know that you can count on the information that you find would be really very helpful. And we do think that they should redesign and simplify and tailor the notice of Medicare benefits. So that again is very much about, I've mentioned some of the the ways we could do that, tailored for employees, tailored for different groups, and to be able to get people the information they need in a digestible way. I think that's the other problem. You get this Medicare New Handbook. It's kind of a thick handbook, and it's really a lot of good, important changes there. But many people put it aside, or they go to the plan finder and they find it complicated. They move away from it, and then they may not do anything about the choices. I mentioned about the age at 64, and last, I will say, and I've referred to this, what we've seen the plan finder really make improvements over the last few years, and appreciate that. More consumer testing has helped that. We do think that there needs to be, needs to continue to be modernized. Again, a way to compare options that fit for you, a way to filter that fits for you, put in your medical conditions, or put in what you, insurance coverage that you have had that you like, things that would really help you be able to sort through all of the different kinds of choices that you have. So we look forward to continuing to work on that. And I want to say we've gotten some, I want to thank all the people who really participated in this report and it really helped guide us. These recommendations are ours as a result of hearing their feedback, but many of them really talked about how they could improve what they do. I'll mention one other too. The SHIP counselors the volunteer counselors are important in this process. Both brokers and agents and SHIP counselors are at no cost to consumers. And that is important to know. The SHIP counselors are run through the states. The state program, grants are given to the state. CMS offers good training materials. Again, those have been updated and modernized in the last few years. That's important. But we do think that each state should be, and those volunteer counselors who do go through training, it's a little uneven across the country, and we need to make that more even by having a really standardized certification for these volunteers. Not too burdensome, they are volunteers, but to actually be able to understand the options and choices that beneficiaries now have. It is more complicated than it used to be, and people deserve to know that what their choices are and be helped with the most up-to-date information. And I also say we've already worked on this, but the report refers to the fact that the materials online or printed or that need to be more culturally sensitive. They need to be language sensitive. We need to be translated into more languages. They're now in English and Spanish. It's not enough. I know they're interested in doing this. They should get started and do it and translate that into more languages and make sure that it is the literacy level is appropriate as well. Make it as simple, easy to read, to understand the options you have so that you, again, make the best choice for yourself. So with that, I think we wanted to say, looking ahead, we have seen projections that over the next decade, we'll continue to see MA enrollment grow, surpassing 50% in this next decade or the end of this decade. And that may even be slightly faster than is projected, but that means in some areas, particularly urban, suburban areas, although we've seen some growth in rural areas in terms of plans going into rural areas in this upcoming 2021 enrollment period, which is something we want to see, which is great. But it is time right now to really work on this, what is still confusing enrollment process that needs to be modernized to help make sure that beneficiaries understand and make an informed choice of coverage. And we put out this, we're going to keep working on this paper. If you're interested in some of our suggestions, you want to know more, take a look at that paper. By all means, be in touch with us. You care about this issue, I know, and we'd love to have your feedback. And if you're interested in getting involved, some of this will take some statutory changes, some are regulatory, but we would love to have you be involved in helping us as a member of the BMA team. And many of you are ally organizations where you really have been helping us in so many ways advocate for a way to strengthen Medicare as a whole and strengthen Medicare Advantage in particular. So you can also connect with a member of the BMA team using the virtual platform on today's summit. And we will post the report. And again, it's easy enough to find. And just excited to be putting forward some of these bold ideas to help seniors be able to make the best choices for ourselves. And with that, I think I'm ready to remind you that you can stay in touch with Better Medicare Alliance. Go on our website, which we also updated just a few months ago, but check out our website for our other research reports and our policy commentary and some of the things I talked about yesterday in terms of the COVID response within Medicare Advantage. We have spotlights on innovation on our website of some of our allies who've done really important and interesting work. We're always interested to hear from you as well as ideas you have that you'd like to see us report on. A telehealth report that was really quite impactful that came out a few months ago. We can just continue to produce these reports. We have another big one coming up in another couple of weeks. I'll highlight a bit more tomorrow. And stay in touch with us. Sign up for those policy alerts. Those are ways that we tell you in a very straightforward, unbiased way, it's without opinion, when we see a new regulation or a legislation or action that we think that you ought to know about. We did one recently on new demo on hospice. All of those are important, and you can pick and choose, and we'll be able to stay up to date. And by all means, take a look at our congressional champions. You have some of them speaking during this conference, but those are members of Congress who and support Medicare Advantage. So thank you to them. So let me now, I think I'm going to turn to what's up next on our agenda. So up next is the presentation or remarks by Secretary Azar, HHS Secretary, and it's my honor to introduce him. He was our keynote speaker last summit, so welcome to the summit, a second appearance in our summits. And I want to also thank him for his leadership. He has done a lot to maintain a stable environment for Medicare Advantage over the last few years, and he has also done quite a bit to offer opportunities for innovation in both fee-for-service and Medicare Advantage that is really benefiting millions of beneficiaries in Medicare. So thank him for his service, and really appreciate the degree to which he continues to be a really good partner to Better Medicare Alliance as well. So with that, please welcome Secretary of Health and Human Services, Alex Azar.